Bismillah ar-Rahman ar-Rahim. I am Dr. Yehia Wahba, Assistant Professor of Pediatrics, Mansoura University Children's Hospital. Today we will talk about lumbar puncture and CSF interpretation. With regard the objectives of our topic are to learn the indications and contraindications of lumbar puncture, to learn both lateral decubitus and sitting position of lumbar puncture, to review complications of lumbar puncture, their precautions and treatments, to interpret CSF findings. What are the indications of lumbar puncture? To obtain CSF for diagnosis of meningitis, meningoencephalitis, subarachnoid hemorrhage, malignancy for diagnosis and treatment, and other neurological syndromes like Guillain-Barré syndrome. What are the contraindications? Unstable patient with cardiovascular or respiratory instability, localized skin or soft tissue infection over puncture site, evidence of unstable bleeding disorder like thrombocytopenia or clotting factor deficiency. Also, increase the ICP, head CT before study if focal neurological finding are present should be done to rule out impending cerebral mass herniation. However, normal CT does not exclude intracranial hypertension. Also, cautions should be taken in patients with Chiari malformations. The required equipments for CSF are anesthetic agents such as topical Emra cream, Elimax, xylocaine cream, lidocaine 1% with 25 gauge needle and syringe, bovidine iodine solution and sponge wand, drapes, gauze and bandages, manometer, stopcock, and tubing in non-infant kits. This figure illustrates CSF equipment. Also, spinal needles, usually 22 gauge, with length 1.5 inch for those less than 1 year, 2.5 inch for 1 year to middle childhood, 3.5 inch for older children and adolescents. A traumatic needle cause less spinal headache. This figure illustrates lateral decubitus position. We should apply at first topical anesthetic 30 to 40 minutes prior to procedure. Spinal cord is known to end at L1, L2, so sites for puncture are located at L3, L4, or L4, L5. Restrain patient in lateral decubitus position. Maximally flex spine without compromising airway. Keep alignment of feet, knees, and hips. Position head to left if right-handed or vice versa. Cleanse skin with bovidine, iodine, and alcohol from puncture site radially out to 10 cm and allow to dry. Drap loop patient and around site with fenestrated drap. Anesthetize with lidocaine. Intradermal rising a wheel at needle insertion site. Advance needle through wheel to desired enter space. Careful not to inject into a blood vessel. Insert spinal needle with stylet with bevel up to keep cutting edge parallel within nerve and ligament fibers. We aim toward umbilicus directing needle slightly cephalic and should hold the needle firmly. A pop of sudden decrease in resistance indicates that ligamentum flavum and dura are punctured as illustrated from this figure. You should remove the stylet and check for flow of spinal fluid. If no fluid, then rotate needle 90 degree and reinsert the stylet and advance the needle slowly, checking frequently for CSF appearance. Jugular vein compression can increase CSF pressure in low flow situations. If bony resistance is felt immediately, then you are not in the spinal interspace. If bone resistance is felt deeply, then withdraw the needle to the skin surface and redirect more cephalic and increase patient flexion. If blood fluid that does not clear or that clots results, then withdraw the needle and reattempt at a different interspace. With regard to manometry, when CSF flow, attach manometer to obtain opening pressure if desired. Pressure can only be accurately measured in lateral decubitus position and in the relaxed patient. Attach manometer with three-way stopcock when free flow of CSF is obtained. Read column when highest level is achieved and respiratory variation is noted. Collect 1 ml of CSF in HO3 vial for first culture and gram stain, second tube for glucose and protein, third tube for cell culture and differential count, and the extra CSF if desired for other lab test. Check losing pressure with manometer if desired. Reinsert stylet and remove needle in one quick motion. Cleanse back and cover puncture site. This is how to do the lumbar puncture in sitting position. Restrain infant in the seated position with maximal spinal flexion. Hold the infant's hands between flexed legs with one hand and flex head with the other hand. Drap patient blue buttocks and fenestrated drap opening over the puncture site. However, you could not measure pressure accurately in this position. With regard to complications of lumbar puncture, we have many complications, but the most common are headache. This complication is unusual below the age of 10 years. Apnea, whether central or obstructive. Back pain, bleeding or fluid leak around the spinal cord. Infection, pain, hematoma, subarachnoid epidermal cyst. Ocular muscle palsy, usually transient. Nerve trauma, brainstem herniation. With regard to spinal headache, it is the most common complication, usually bilateral, improve in supine position, could last from hours to weeks. For relieving it, you should put the patient supine position for at least 2 hours with good hydration, caffeine either per oral or parenteral. To prevent spinal headache, pass the needle bevel parallel to longitudinal fibers of the dura. Replace stylet before removing a needle, using small diameter needles, using atraumatic needles. Bed rest or for oral intake after lumbar puncture does not reduce the incidence of headache. With regard to epidermal inclusion cyst, it is very rare nowadays due to the use of stylet. Occur when a core of skin is driven into spinal or paraspinal space with hollow needle. Don't remove stylet until through the skin. With regard to failure of procedure, it could occur. However, if it is urgent to do CSF after failure, we have certain alternatives, including having someone else to try, especially if he is in the field of anesthesia or neurology. Bedside ultrasound for difficult lumbar puncture. Also, radiographic guiding procedures like fluoroscopy, ultrasonography, and CT. Cisterna magna tapping. How to interpret CSF. Macroscopic examination. Total volume. In adults, it is known that CSF volume is 90 to 150 millimeter. In children, it is 10 to 90 milliliter. Its production rate is 0.35 milli per minute. It's distributed in the ventricles reaching 20 milli, in subarachnoid space about 60 milli, 70 milli in spinal canal. It's a specific gravity ranging from 1.006 to 1.008. pH is usually alkaline. With regard to appearance, normal CSF is clear with consistency of water. The major terminology used to describe CSF appearance include clear, cloudy, turbid, milky, or bloody. Cloudy, turbid, or milky means increased protein or lipid concentration, but it may be also indicative of infection, may be caused by WBCs over 200 cells per microliter, RBCs over 400 cells per microliter. With regard to microscopic examination, CSF cell count, normal CSF RBCs are less than 5 per higher power field. Counts that are otherwise unexplained may be due to a traumatic tap. It is to be noted that cell counts should be done within 30 minutes after withdrawal of the specimen to avoid cell disintegration. Specimens that can't be analyzed immediately should be refrigerated. Normal CSF contain 0 to 5 WBCs per high power field. In adults, the number is higher in children and as many as 30 to 50 WBCs per cubic centimeter could be considered normal in newborn. With regard to biochemical examination, CSF glucose concentration is slightly lower than that plasma and usually between 60 to 70% of plasma glucose concentration. The normal range of CSF glucose is between 50 and 80 mg per deciliter. The blood glucose sample is needed for comparison. The blood glucose should be withdrawn about 2 hours prior to the spinal tap to allow time for equilibration between the blood and fluid. With regard to protein, normal CSF protein concentration is less than 1% of serum protein concentration and usually listed as 15 to 65 mg per deciliter. A rise in CSF protein is seen in various diseases as a result of 3 primary mechanisms: decreased clearance of normal protein from the fluid and the degeneration of neural tissue, increased local synthesis of immunoglobulin, increased capillary permeability due to blood-brain barrier damage. With regard to CSF lactate, lactate concentration in CSF may be useful as a part of the investigation of important errors of metabolism in which lactic acidosis occurs. This includes disorders of gluconeogenesis, pyruvate dehydrogenase complex, Krebs cycle, and the mitochondrial electron transport chain. In bacterial, tubercular, and fungal meningitis, elevation of CSF lactate greater than 25 mg per deciliter is found. With regard to microbiology test, with bacterial infection, the gram stain is important because this indicates the initial choice of antibiotic. Gram-negative diplococci, whether intracellular or extracellular, are indicative of Neisseria meningitidis. Small gram-negative bacilli may include Haemophilus influenza, especially in children. Gram-positive cocci indicate Strep pneumoniae or Staph cocci. This table summarizes how to differentiate between normal, viral, bacterial, TB, fungal, malignant conditions using different parameters like cell culture, cell type, cell count, glucose, protein, and gram stain. While doing differential diagnosis of meningitis, we will find that a total leukocytic count is increased in all types, including bacterial, viral, tubercular, and fungal. The more predominant type of cell in bacterial is neutrophil, while lymphocytes are the predominant in viral. Lymphocytes and monocytes are common in tubercular and fungal. Protein content is markedly increased in bacterial, moderately increased in viral, moderate to markedly increased in tubercular and fungal. While glucose content is markedly decreased in bacterial, normal in viral, decreased in tubercular, and normal to decreased in fungal. Lactate concentration is more than 35 mg per deciliter for bacteria, normal in viral, more than 25 mg per deciliter in tubercular and fungal. When doing gram stain, it will be positive for bacterial, while positive India ink with Cryptococcus neoformans is found in fungal. With regard to immunological screening, it will be positive bacterial antigen screening for bacteria, while other immunological tests are reported with fungal etiology. With regard to important questions about our topic, by the end of our topic, what are the indications of CSF study? What are the complications and the contraindication of this procedure? Could you list the equipment required to do? How to differentiate between bacterial and viral meningitis? By the end of this lecture, you could answer all these questions. This slide represents links for important videos used to illustrate how to do the lumbar puncture both in lateral decubitus and sitting positions. Thank you.